Hello and welcome back to the Medical Entrepreneur IV Chelation Training Series. I'm Adam Sewell, MD, and in this video B1, we're going to talk about patient selection and workup for IV chelation therapy. Before we begin, here's our important disclaimer. All the information provided here is for educational purposes only and does not replace your independent clinical judgment, official guidelines, or local regulations. Always consult the appropriate references, specialists, and your governing bodies before implementing any treatment. Now let's dive into the key steps for identifying appropriate patients for IV chelation. The first critical step is to assess heavy metal levels in the patient's body. This often involves blood tests, blood lead level, BLL, if you suspect lead poisoning, checking for iron overload with serum ferritin and transferrin saturation if needed. Mercury and arsenic can also be measured in blood, though some forms are more reliably detected in urine. Urine tests, 24-hour urine arsenic for suspected arsenic toxicity, urinary mercury levels, especially in patients with industrial or dental exposure. Accurate lab work is the foundation of deciding whether chelation is indicated. Next, we need to correlate these lab values with the patient's clinical presentation, symptoms, environment, and potential comorbidities. Let's look at why that's crucial. Symptoms. Neurological signs, tremors, memory loss might suggest mercury or lead. Gastrointestinal distress could indicate acute arsenic exposure. Fatigue and chronic aches could be linked to various metals. Exposures, occupational or hobby-related, for example, battery manufacturing for lead, smelting for arsenic, dental amalgam work for mercury. Living in older homes with lead paint or drinking well water with possible arsenic contamination. Comorbidities, renal insufficiency, as chelators are excreted by the kidneys. Cardiac issues if there's a risk of arrhythmias or fluid overload, hypocalcemia or other electrolyte disorders if using EDTA. All of these factors help you decide whether IV chelation is appropriate and safe. Now the big question is, when do we actually treat? Let's talk about setting those all-important treatment thresholds. Different guidelines suggest different thresholds, but here are some commonly accepted benchmarks. Lead, consider IV chelation at a blood lead level, BLL, greater than or equal to 45 micrograms per deciliter, especially if there are symptoms or ongoing exposure. Mercury, elevated urinary mercury combined with neurological or renal symptoms often prompts chelation. Arsenic, acute arsenic poisoning with high levels typically warrants immediate chelation. Chronic exposure may also require treatment if levels remain elevated and symptoms persist. Iron overload, ferritin above 1,000 to 2,000 nanograms per milliliter, especially with evidence of organ damage, liver, heart, can indicate the need for IV chelation, for example with deferoxamine. These numbers can vary based on geographical location, clinical guidelines, and patient-specific factors. Always interpret them alongside the overall clinical picture. So to recap, 1. Assess heavy metal levels through accurate lab tests. 2. Review symptoms, exposures, and comorbidities to ensure that any elevated metal levels correlate with real-world clinical concerns. 3. Set treatment thresholds based on accepted guidelines and individual patient factors, like a BLL of 45 micrograms per deciliter or higher in symptomatic lead-exposed patients. By following these steps, you'll be well prepared to decide who truly needs IV chelation and when to start it. In our next video, Video B2, we'll explore the IV chelation administration protocols, including how to dose and monitor these therapies safely. Thank you for joining me, Adam Sewell, MD, in this installment of the Medical Entrepreneur IV Chelation Training Series. I'll see you in the next video.